Madam, my dear colleagues, friends, and PGs across the state and across the India. Many from outside Kerala also joined this group. Today, the third talk on IAP Kozhikode PG Club. Today we will have Lulu Madam. Madam will speak on OSCE, nothing great about it. I am very surprised by this heading because Madam is one of the academicians who started using OSCE as an evaluation tool even before the DNB and many universities used it. So today we will hear from such an academician who will talk you about the OSCE. And we all know the DNB final examination is scheduled on 28th July. So definitely it will be a useful session for the exam going DNB students. With these words, with a lot of regards and affection, I invite Lulu Madam to this platform. Over to you, Lulu Madam.
Okay, IAP Calicut, I am really indebted to you for remembering me exactly 10 years after I quit my service. And I really thank Ashraf. Incidentally, I was not at all happy about accepting this, but he would not let me go. I tried to slip out, but he would not. So I am here and you have to suffer me. That's all. So let me start my screen sharing. Yeah, yesterday Ashraf rang up and asked me, what is the title of your talk? I said, what is there? Should there be a title? He said, there should be one. So I said, okay, nothing great about it. OSCE, nothing great about it. I really don't think there is much to worry about OSCE. It all depends upon the candidate's attitude. If you look at OSCE and smile, you will be like this fellow here. But if you always grumble thinking about OSCE, you will be like this fellow. That's all. And incidentally, I'm sure you candidates would have listened to that counseling which you had from Delhi about OSCE. I too logged in because, you know, I am also now teaching a few DNB graduates. So I also listened to it. And then I realized some changes would be there, bringing about some changes in OSCE start for this year, being the pandemic. And so 10 days back only, Ashraf told me, for the past 10 days, I was slipping past. I mean, I also imagined that I was in my mid-30s. Only then I will be able to prepare a good set of questions. So the past 10 days, I was quite young mentally. Okay. And then, so now I have decided, I'm not, I mean, I know yesterday you had 25 to 30 stations and so on, but today I'm just giving you 12 stations, that's all. And some time I'll be giving you. And after each question, I'll be giving you time to answer. And please don't come on the chat box. You have a paper and a pen with you. And when I give the time, you put down your answer. I've asked Krishna Mohan. He will help me in keeping the time. And I can see him. And thank you, Krishna Mohan, for being here. So when I was listening to that counseling, I realized today's or the coming OSCE has some good sides, but also some not so good sides. What are the good sides? And one is that you see, normally, usually, when I ask my students, how was the OSCE? You people tell me, oh, madam, I had studied, but you see, my first station was statistics. I didn't even understand the question. And because I did so badly, the subsequent 4 or 5 stations, I knew, but I could not answer. So now you are all lucky because you're all sitting in a hall and the stations are coming on the screen. So all of you are starting on station 1. After that, you go to station 2 and so on. So no question of somebody starting being unlucky enough to start on statistics station. And again, you don't have to run around and bang against chairs and examiners, because sometimes we see candidates are so, because even as they're sitting in station 1, they're looking around, where is station 2? Where is station 2? And they get out, and in the process, you bang against the chair, against the screen, against the wall, and sometimes even against the examiners. And the third good side is that you don't have to come face to face with the examiners. No counseling stations. Again, this is an often repeated, often you tell me, see, the counseling question was very good, but that examiner had such a grumpy faces. I forgot all what I wanted to ask. So again, you are lucky you are not coming face to face with examiners at OSCE. But of course, for a clinical examination, you will be, that's a very different entity. And again, from that Delhi session, I understood marks are also given along with the questions. And that will indeed help you. I'll tell you how it is going to help you. Now, the not so good things. See, before they had said that compulsory 50% marks for a pass in OSCE and compulsory 50% for the rest. But that I thought was not so good, because it's very difficult. However good you do your clinicals, if they insist that you need to get 50% in OSCE, that's not a good thing. But again, the candidates have received intimation from Delhi that they have taken out that clause. Now altogether, you need get only 150 out of 300. So that's good. And again, now the OSCE mark has been upscaled from 150 to 200. That is not so good. And again, no NALS and PAL stations for OSCE. See, normally I've been examiner on several occasions. What I say is that these stations have very good marks, like 14, 16, and you are also thorough with it. You just come there and start, you go. And most of you get around 90 to 95% for NALS and PALs. So that is not there. Then again, no counseling stations. Before, you could say good morning, thank you, sorry, what's your name, and end up gaining marks. But no counseling stations, and you will not get marks for telling thank you and sorry. And again, no transfer of time possible. I'll tell you what transfer of time is when I come to these stations. So now please, those of the candidates who are here, please take a paper and pen and note down the answer in the paper, not in the chat box. Okay. Station 1, 10-year-old David, weight 60 kg, height 150 centimeters. Calculate the BMI, your inference about his BMI. Name 2 genes implicated in his problem. Krishnamohan, 30 seconds. You will be given 30 seconds. You answer this question in your paper, not in the chat box. Okay. So next, the question continues. What is POMC deficiency? And name the constituents of POMC. 15 seconds, Krishnamohan. Again continues. Name a common genetic syndrome where insatiable appetite is associated with obesity. You please look at the marks given side by side. And what is human microbiome? 30 seconds.
Yes, 30 seconds.
Okay. Now I shall give the answers. Please correct your papers. See, what did you think about when I showed you calculate? First thought, oh my God, I have not brought my calculator. Or they are not giving the curves. But you see the figures, it is 60 and 15. So anybody can do it without a calculator. So, I mean, you don't require a chart, you don't require a calculator. So, unnecessarily, you were thinking and you lost about 10 seconds. Okay. And the condition is obesity. And two genes are implicated FTO, situated on chromosome 16, and M4 receptor. That is that receptor that is responsible for the food seeking behavior. That's not needed, but I'm just mentioning it. So you mention the names of two genes and you get 2 marks. Now, what is POMC deficiency? Okay, pro-opiomelanocortin deficiency. And that is actually a precursor of ACTH and, I mean, it's not needed. Some of the things I'm mentioning because you see, it might be helpful later on. And melanocyte stimulating hormone. So what are the features? So again, if you look at the question had 1.5 marks. What does that show? Then you should guess 1.5 means there should be, 2 marks, sorry, 2 marks. There should be 4 features. That is how I told you the marks being given will help you. So 2 marks means you should guess, okay, there are 4 points. So that is adrenal insufficiency, light skin, hyperphagia, obesity. So 4 you write and you get 2 marks. Okay. The question again continues. This I am sure all of you will get it right. Prader-Willi. Every one of you would have got it right. And now what is the genetic material of all the microbes, bacteria, virus, fungi, protozoa, living on and inside the body, regulate the metabolism. Okay. And actually, this environment contains 200 times the number of genes than in the human genome. So that is becoming more and more important now. And that is what is known as. Okay, so that is again 1 mark. Okay, isn't it 1 mark? Let me check. Okay, human microbiome, 1 mark. So this is how I have arranged the marks for station 1. And again, as was shown in Delhi, they are revealing the questions part by part. And once that slide goes away, then the rest of the questions are coming. So that is the reason why I am showing you like this. So is it clear now? I hope you have 8 marks, I think, for this station. You see how many marks you have got. Okay. Now station 2. A 12-year-old girl from non-endemic area having diffuse thyroid swelling, no other symptoms. Mother also had a similar swelling as a schoolgirl. Question: what is your diagnosis? Why do you say so? Following tests ordered, what would be the reports? TSH, thyroid antibody, scintigraphy. Krishnamohan, 30 seconds.
Yes.
Now the question continues. Closest one differential diagnosis. Closest one DD. And what investigation is needed to differentiate your diagnosis from the above DD? Again, 1 mark. 30 seconds.
Yes.
Now, so diagnosis is very evident, simple, go ahead. Why do you say so? Look at it, 1.5 marks. That shows 3 points. So the gender, girl, age, adolescent, family history, classical 3 features. So that is why 1.5 marks. And closest DD, lymphoid thyroiditis. And the investigation to be done, biopsy. So that is how, okay, station 2. Now, station 3. Ram is suspected to be suffering from autoimmune polyendocrinopathy type 2, and he is under follow-up. Which are the most common?
Kind of question, investigation we discuss.
Oh,
Station
sorry.
2.
Okay, sorry. TSH is normal or low, you get 1 mark. Thyroid antibodies would be negative, 1 mark. Scintigraphy also will be normal. 3 investigations I had given, and you had to write what would be the report. Sorry. Ram is suspected to be suffering from autoimmune polyendocrinopathy type 2, and he is under follow-up. Which are the most commonly involved endocrine glands in this condition? 15 seconds.
Yes.
Ram, then he was under follow-up. After some time, he comes with extensive mucocutaneous candidiasis. What other related condition would you consider as diagnostic possibility? 1.5 marks. Name Whittaker's triad components. 1.5 marks. Most commonly involved 2 glands in the revised diagnosis. 30 seconds.
Yes.
Okay. Now, what are the most commonly involved glands? 1.5 marks. That shows 3 glands will be there. 3. So, adrenal, thyroid, and pancreas. And next is what is a related condition? So, it should be a polyendocrinopathy as well as associated with, that was the clue, mucocutaneous extensive involvement. That means you should be considering type 1 autoimmune polyendocrinopathy. So each word is important. Just because extensive, mucocutaneous, don't think of HIV. Look at that question, related. Related means it should be related to the present condition, and he is under follow-up, right? And then, so what are the components of Whittaker's triad? Mucocutaneous candidiasis, primary hypoparathyroidism, primary adrenal insufficiency. Three features, Whittaker's triad. And then now what are the 2 glands most commonly involved in type 1? That would be parathyroids and adrenals, 2 marks. So this, if anybody has considered immune deficiency because it is the style now, or even HIV, please read the question properly. Related, and that is the word, related. Now, station 4, 8 photographs I am giving. Each slide has 2 pictures. Write down the diagnosis, the clue is given. And each slide will be shown for 15 seconds, each slide. Krishna Mohan, 15 seconds. A term baby, palms and soles free, right stain shows eosinophils. Take the clue. Fever, arthralgia, painful lesions, repeated similar episodes.
15 seconds.
See this, if you know it, otherwise you don't know. Affecting large areas, pain, positive or negative, may or may not be present, itchy, lasting few days to months. Over the trunk, serpiginous, non-pruritic. All these are 15 seconds, Krishnamohan.
Yes.
A not ill reticulate pattern, slap cheek. 10-year-old boy, pruritus lasting 6 to 7 days.
Yes.
High fever with few blisters. Corine bacterium, minutissimum, toe webs, axillae, groins, bright coral red.
Yes.
Now let us see the responses. Okay, station 4. This was the first slide. I mean, this is so easy, this baby eosinophils, that is the classical clue. Anybody will take it as ETN, erythema toxicum neonatorum. The second one, what is this? Tender red nodules, indistinct borders, see the borders, and repeated similar episodes. That was the clue for this. So that is erythema nodosum. And again, you should remember, as a result of group A streptococcal infection, Yersinia, and also it can follow drugs like cephalosporin, penicillin, and macrolates. Not needed, I just mentioned it. But the clue you should have taken is repeated similar episodes. Okay, this is the second slide. Okay, so what are they? Let's see. Erythema chronicum migrans, that is in Lyme disease. So I am sure some of you at least would have thought this is a target lesion. Target lesion. But the clue is lasting few days to months. This is the cat. That is why it is known as erythema chronicum migrans. So that was the clue. This also has a bullseye pattern, as you see, follows tick bite, appears within 3 to 30 days of tick bite, pain may or may not be present, and itchy. So the clue you should have taken is lasting for a long time. Okay, this I am sure you would have got it right. Erythema marginatum, trunk, non-pruritic. But what is it that you can go wrong? Some of you might think it is an urticaria. Urticaria, there will be pruritus. There will be. So that is why I've marked it red, non-pruritic. I mean, I will not blame anybody if you diagnose urticaria exactly like this, but non-pruritic. That is the thing which should make you consider other diagnostic possibilities. Next is this one. Okay, so this is erythema infectiosum, that slapped cheek and not ill appearance. That is the clue. I'm sure most of you would have got it right. See, in spite of that intense rash, how bright the child baby looks. Also known as fifth disease. In childhood, rash is very prominent. But please remember, older children can also get it, and they can have polyarthralgia. Polyarthralgia. Okay, and it starts as rash and later acquires the reticular pattern with central clearing. Okay, so this is second one. This is erythema multiforme. Erythema multiforme. So what was the clue? The target lesion that can be seen very well, and pruritus lasting 6 to 7 days. So you should know, I mean, the most important points I've given as clue. And it occurs as hypersensitivity to herpes simplex, and there is an erythema minor, erythema multiforme minor, only cutaneous, with a minimal mucosal involvement, Of at all, only one site, and that is the mouth. Whereas erythema multiforme major, 2 or more mucosal lesions and severe oral lesions are possible. I just mentioned it, that's not needed. What you have to do is just diagnose erythema multiforme and you get 1 mark. High fever with few blisters and this. Okay. So you see, erysipelas. See the sick look of the child. And what was the clue here? Intense rash, high fever and some blisters. That is the clue. Follows group A streptococcal infection, swollen red tenter, and systemic features are very prominent, also known as St. Anthony's fire. Okay, before in those days, whenever a child got erysipelas, they used to go to a church where St. Anthony was the saint. That is why it is known as St. Anthony's fire. Okay, so this is it. Yeah, one more, sorry. So, sorry. See here, the lesions are sharply demarcated. Irregular borders. See how well it is demarcated. Slightly scaly. Predisposing factors are obesity, diabetes mellitus, poor hygiene. In fact, I had given in the clue that in a child boy with unclean habits. These organisms produce porphyrins. So if you look at it under UV light, you get the coral red color. That is very characteristic. That is why it was given there. And diagnosis, wood lamp examination, and it will respond to topical macrolates. So 8. And what this was what I meant by transfer of time not possible. You see, if it is a conventional OSCE, you would be given all these photographs. And you can take your time, 1 or 2, you get it quickly, so that you write the diagnosis. And for the others, you can utilize all the time. But here it is not like that. The slide keeps changing after about 15 to 20 seconds or whatever time. And again, you have, for example, here, the first child, suppose you wrote erythema infectiosum. And then when you came to the 4th slide, you are thinking, oh, this is erythema infectiosum. That means the first one is a different. If it is in a paper, you can at once correct it. But here, the slide has come off. The paper is in front of you, and you don't remember which slide was it. Was it first slide, second slide? Was it on the left side, right side? So though you know you have made a mistake, you cannot correct it. That's what I said. Transfer of time is not possible in this OSCE because the image is gone. Whereas in the conventional OSCE, all the 8 photographs are in front of you, and 2 or 3 you know very well, very little time, and all the rest you can utilize all the time. So that is very important. That is how the questions were shown. I told you, I logged in, I attended the OSCE. That is how it was shown. And he specifically said the slide will not be repeated. Station 5. Mohan and Sini have come to a genetic clinic. Sini is pregnant. Mohan's mother and Sini's father are siblings. Sini's first pregnancy abortion, female anencephaly. Second pregnancy abortion, male unaffected. Third pregnancy occurred soon after MTP done. Fourth pregnancy ectopic MTP done. This is her 5th pregnancy. Mohan's elder brother died in infancy. Sini's younger sister also died in infancy. Krishna Mohan, you can give them 45 seconds. Draw the pedigree chart with the given details. Draw the pedigree chart with the given details. 45 seconds.
Yes.
Okay. Now, You must all be, oh my God, where to start? How is Mohan's father? How do I draw it? So you'll be thoroughly confused. So my advice to you is that you start on at whichever point you know. See, for example, you know Mohan and Sini are related. So you draw Mohan and Sini and this line, and that will fetch you 0.5 marks. Okay. And now they are not the patients, they are the consultants. They have come for consultation. So this is how it is marked. Okay. They are not darkened. If they are patient, you know, in they're darkened or some other symbol. They are consultant. They have come for consultation. So here, if you have drawn like this and join them, you get 1 mark. Okay. Now the next thing. What happened to her first child? Okay, it is an abortion. So this is how you depict abortion. And you also have to write there anencephaly and female. That is given. That is given. So 1.5 marks. Second also ended in an abortion. It is male. Sorry, this should not be colored. Got a blue illa. It's and male. So again, 1 mark for triangle and male. And third is MTP was done. So a triangle with a cut, 0.5 mark. Was ectopic and so MTP. So a cut, a triangle and ECT, 1 mark. And present pregnancy P, 0.5 marks. So if you know so much, so many marks you can get. Okay, 4.5 plus 1, 5.5 out of the 8 marks you can get. Don't think you have to start right from the top. Don't you start wherever, at whichever point you know, you start from there. That is the beauty, that's the good side of OSCE. For anything you write the right answer, you get marks. And again, this also you know. So Mohan has an elder brother who died in infancy. It is shown like this and written there, infancy. And Sini had a younger sister who died in infancy. Again, 0.5, 0.5, 1 mark. Okay. Now that their fathers. So now this you can take some time because altogether now you have written sufficient enough to get 6.5 marks. Okay. On the other hand, if you start from the grandparents, you will inevitably, you will go wrong. Okay. So now that you know, this is Mohan, this is Mohan, this is Sini. So they have parents. Both of them have parents, sorry. And these two are siblings. Okay. So that part which you think you will have difficulty, you keep to the last. Even if you don't get it, only 1.5 marks you will lose. You will get the other 6.5 marks which you know. So that should be the way in which you answer OSCE. So this it appears to be a little confusing, but it is not. If you start from the point which you are thorough, don't ever start from the top. Usually you will get it wrong. Okay. Now station 6. As the admitting medical officer, what are the steps to be taken on admitting a child with acute flaccid paralysis? And what are the precautions to be taken in sample collection? 30 seconds. Krishna Mohan.
Yes.
Continues. Write 2 indicators of AFP surveillance program. 2 indicators. Name the other specimens which can be collected other than stool. Who is contact VAP? Who is recipient VAP? 30 seconds.
Yes, madam.
Now the answer. See, the first question, the marks were 2. So you should know, there are 4 points. Proper stool sample collection, filling in the appropriate laboratory form, informing the concerned officer, forwarding the sample in proper cold chain. These are the 4 duties of the admitting medical officer. So 4 points, 2 marks. And then again about the what are the precautions to be taken? 1.5 marks. You know the stool has a lot of description, so it cannot be 3 points. There will be more. So whenever you are in doubt, write all the points which you know. Okay, because here 6 points, 2 stool samples, 24 to 48 hours apart, within 14 days, 8 to 10 gram size, good condition, without leak, without drying. So 6 points, 0.25 each, 1.5 marks. So that is how I told you math should be helping you. You will get an idea what is expected of you. Then you may not know polio surveillance, what are the indicators. So leave it at that point, then go to the next question. I'll come back to it. So what are the other samples? And again, 1.5 marks. That should tell you there are 3 other specimens. So even if you don't know, just think what else can it be? Serum, CSF, nasopharyngeal swab. Okay, so who is a recipient VAP is that the person has developed AFP within 4 to 30 days of receiving OPV. That is recipient VAP. And contact VAP is AFP appearing within 4 to 75 days of coming into contact with the recipient of OPV. So if you write that, you get 0.75 into 2, 1.5 marks. Okay. Now coming to that surveillance, there are I think 6 or 7, but I have asked only two. And here I have given you 4. One is that for if you take the children less than 15 years, for every 1 lakh, at least 1 AFP should be reported. Okay, so if there are 3 lakhs of children below 15, 3 should be reported. Another point is that the percentage of AFP cases investigated within 48 hours should be 80%. And again, adequacy of proper stool collection should be 80%. Or specimen reaching the lab in good condition should be 80%. There are, I think, 3 or 4. You please go back and refer this. I think there are altogether 6 or 7. So only 2 I have asked you. If you write that, you get 1.5 marks. Station 7. Newborn presenting with respiratory distress. Look at the given pictures. What's your diagnosis? Inheritance pattern, 15 seconds.
Yes, madam.
This condition is due to defect in dash. Give one very close DD. These conditions are grouped under the common terminology dash. 15 seconds.
Yes.
Name 2 conditions which resemble rickets but without the classical biochemical changes of rickets. The recommended daily upper intake of vitamin D for long-term use in children. 30 seconds.
Yes, madam.
Okay. So what's the diagnosis? I'm sure you would have got it as asphyxiating thoracic dystrophy or June syndrome. It is autosomal recessive, and the primary defect is in the primary cilia, closest like Ellis Van Creveld syndrome. And these are now collectively grouped under ciliopathies. Ciliopathies, because it is known the primary problem is in the cilia. Now, the next thing, okay, what are the conditions mimicking rickets? One is hypophosphatasia, second is metaphyseal dysostosis, Janssen and Schmidt type. Okay, and then again, 1,000 units, 1,000 units of vitamin D in children below 1 year, and 2,000 units in older kids daily, if you are going to give on a long-term basis. Now, there's a specific reason why I mixed up June syndrome with rickets, this question on rickets. You know, years back, I think it was in 2006, when DNB examination was done in Calicut, there was a question on the picture, pathology slide shown was gametocytes, and one or two questions related to malaria. But after that, two questions regarding how to differentiate a myeloblast from a lymphoblast. You know, and I corrected that station, and when I was valuing this, I saw so many candidates who had written malaria, cut it and writing leukemia, because they thought the subsequent questions are on leukemia. So maybe the slide is also leukemia. That is the exact reason why I mixed up this. When you read this question on rickets, suddenly you will think, oh, the other one, because you know that slide is gone. That slide was shown initially, and now you can only recollect it. Oh, that was a slender, maybe there was flaring, I missed it. That hand was shown. Okay, I thought it was polydactyly. Maybe there was epiphyseal widening, because now you can't go back and look at it because that slide is gone now. So when your memory recall, you get it wrong, and you person who wrote June syndrome cuts it, and because paper is with you, only after each station the paper will be collected from you. That's what is mentioned there. So this belongs to the same station. So please don't think that anything which comes in one station, they all belong to the same diagnosis. So this happened, and I have seen 3 or 4 candidates got it wrong. After initially diagnosing it as malaria, they cut it and wrote leukemia. So that is why I mixed it up like this. So please remember this. Okay. Now classify the following analgesics into non-opioids, weak opioids, strong opioids, co-analgesics. There are 12. I give you 30 seconds. Ashraf, I'll stop at 6:30, sure.
You can take more time if needed. It was very, very interesting.
Yes, madam.
So non-opioids, Colicocip and ketorolac. You may have got ketorolac wrong, because you know the sound, it looks as if it is an opioid, but it is not an opioid. They have named it like that. That is all, the company. It's a pure NSAID. Okay. Now weak opioids are tramadol, tapentadol, and codeine. These are the weak opioids. Please remember, we don't use codeine in children because it is severely constipating. And secondly, codeine has to get converted into morphine in the body. So 10 mg codeine gets converted into 1 milligram morphine. And this conversion may not occur in all children. So we don't use codeine in children. We don't again use tramadol, because tramadol can lower the seizure threshold. And you know, children have a propensity for febrile seizures. So for that reason, we don't use tramadol also. This is just, I'm telling for comparison's, just information's sake. So weak opioids are 3. Now, strong opioids, buprenorphine, methadone, alphentanil is nothing but a branch form of fentanyl, hydromorphone. All these are strong opioids. What are co-analgesics? Co-analgesics are drugs which are in the market for another indication. See, dexamethasone is an anti-inflammatory. Carbamazepine is an anti-convulsant. You know, so certain drugs which are in the market with primary indications, it's not at all related to analgesia. Primarily, they are indicated for other purposes. But we have seen they are very useful in relieving pain. They are known as co-analgesics. Valparic acid, valparin, all the anticonvulsants, so many, they are all come under the group of co-analgesics. Even ketamine, used as an anesthetic agent, but that is also a co-analgesic. So co-analgesics are those drugs which are primarily used for other purpose, but which can be used as analgesics. So 12, 6 marks, half mark each. Now, name of this instrument. What is the utility? "15 seconds.
Yes.
So this is Wong-Baker-Face's pain rating scale. You know, when small children, say for a child above 4 or 5 years, you can show this face and tell him, auntie or uncle knows you have pain. Okay, which among these is your face? You don't give the, you are asking the child, which among these is your face? Suppose he says, this is my face. That means his pain is 8/10. That means he has severe pain. That is how it is used to assess pain in children. Von Baker Face's pain rating scale. So even if you write just Von Baker scale, you will get marks. But the full name is Von Baker Face's pain rating scale. The advantage is that any language, any culture, all over the world, you can use this scale to assess pain in children, because they don't know the meaning of mild pain, moderate pain, severe pain. You are giving them an opportunity to give a value to their pain, so you get to know how much pain that child is suffering. Okay. So herewith is a list of antiemetics. The list of receptors are also given. For each antiemetic, choose the receptor which has the best action. Hyoscine, cyclosine, haloperidol, 30 seconds. Metoclopramide, domperidone, aprepitant, olanzapine. They are all antiemetics. Why I selected this? Because I saw a question giving the drugs and the action of how these drugs cause liver damage. Once they have asked that question. Okay, so some act by cholestasis, some by causing cellular damage, some by different mechanisms. So here, that is why I chose antiemetic.
Yes, 30 seconds over.
Okay, 8. So if you get right, 1 mark each. See, hyoscine, it is acetylcholine receptor. Cyclosine is a pure histamine. Okay. Haloperidine, dopamine. And the cetrans are serotonin, 5-HT3. Metoclopramide can act both dopamine and on serotonin. That means it can act both centrally as well as peripherally. That is the beauty of metoclopramide. That is why so many conditions we use metoclopramide being used. Domperidone has only peripheral action, only dopamine. Aprepitant has action only on the NK. NK is the neurokinin. Okay. Olanzapine has various levels action. So why is it important that you should have an idea about receptor? This is not a pure theory question. The reason is, you see, cyclizine, antihistamine, very good for motion sickness. If you use Emicet, you will not get as much result for motion sickness as you use an antihistamine. Haloperidol, centrally acting, very good for metabolic conditions like diabetes mellitus, electrolyte imbalance, uremia, hypercalcemia, and again drugs like morphine acting centrally. Very good haloperidol. Cetrans are very good for chemotherapy-induced nausea, vomiting, and radiotherapy-induced nausea and vomiting. Metoclopramide acts centrally and peripherally. They can stimulate the gut, and also good because it acts centrally. It can be the antiemetic for morphine-induced vomiting. Domperidone, only peripheral action. So only for problems related to gut. Aprepitant is, I told you, it's a neurokinin, good for chemotherapy induced. And again, olanzapine also chemotherapy induced. So when you choose an antiemetic, only if you have an idea what the receptor is, you will be able to choose the right receptor, right antiemetic. Fill up the stations with decrease, increase, normal. Hemophilia, 30 seconds. Congenital afibrinogenemia, warfarin, factor 13. Just write IDN.
Thirty seconds over.
Okay. So now, see again, when you see this, don't get very upset. You first fill in those which you know. I'm sure you know hemophilia, normal prothrombin time. That you know, so you write that. Okay. Whereas von Willebrand, you may be doubtful, especially type 3. Leave it at that level. Congenital afibrinogenemia, that definitely it's a condition, all the are increased. Warfarin, I'm sure you will be able to say prothrombin is increased. That you will know, toxicity. If you don't know the rest, you leave it. So my advice would be, don't try to fill all the columns. You write all what you know. And then if you have the time, come back and fill it. Factor 13, you have been told 100 times, that is one condition where all the values will be normal. So again here, see, 15 are there. So half each, half mark each for each correct answer. 7.5 marks. These are 5 curves showing serology in hepatitis B. The curves are numbered. Please indicate what each curve depicts. So just write what each curve depicts. 30 seconds.
Yes, madam.
Now, this is what the answer is. You see, this curve depicts hepatitis surface antigen, the first one. The second one is this E antigen. Okay. The third one, you see the anti-C antibody. and then E antibody, and then surface antibody. So this is the response. But why did I put this question is, if you refer the latest edition of Nelson, the picture is slightly different. This is the picture in Nelson. I'll give you that. You see here it appears as if E antigen appears first. So I really don't know. So as far as what I have learned, the surface, I referred a lot. Everywhere the thing is surface antigen appears first. So I would advise you, Nelson, I don't think mistakes will also occur. And do you know how I used to teach this to my students when I was in medical college? I used to say a sage with canes, sage antigen. The first to appear is S, then E. With canes, AN is antibodies. First antibody to come is anti-C, then anti-E, and then anti-S. So this is how I remember, and this is what I used to teach my students. But now I got the latest Nelson, and when I looked over it, I find that this is the picture which is given there, and here hepatitis E antigen comes ahead of the S antigen. So please, I mean, it all depends upon, suppose the question is taken, it all depends upon which picture they have taken from which book. Now, this is last question. Some chemicals which result in poisoning. That is in column A. Column B gives the names of household items which contain these chemicals. Match. Write only the number and the corresponding alphabet. See, why did I choose this? There will be a question on poisoning. See, and each year, you know, they go for different sections. So that is why I took this inhalants. They are all inhalants. 30 seconds.
Yes, madam.
Okay. So I'm sure you will be very upset with this question. You will be upset. So what can be, no. Name 2 chemicals which can result in sudden sniffing death syndrome. And what is huffing? 30 seconds.
Yes.
Now, this one, you see, what will you do? Whatever you know, for example, I'm sure whenever any refrigerator boy comes, he'll always, Madam, Freon boy na thonana, Freon, that we have heard. So Freon you can put. And then again, if you look at it, see, unless and until you have looked at, you have read this portion, it's very difficult. So what I would do, I would pray to God and arrange it in one order. If marks have gone, let it go. What can I do? So don't be very upset about the fact that you have, and because only how many? 1, 2, 3, 4, 6. 6 marks for this. How many marks? What was the marks I had put? I forgot. Yeah, 6 marks. And name 2 chemicals which can result. Amyl nitrate, butane, freon, and trichloroethylene. What is sudden sniffing death syndrome? That is, you know, if you inhale this, even for the, sometimes even for the first time, sudden death due to cardiac arrest. This is well known in Western countries. And these are the agents. I asked you only two. If you write two right answers, you get two. What is huffing? Again, this is very common in adolescents. So inhaling fumes using a paper bag, and bag contains a chemical soaked cloth. And chemicals will be any of the ones which I have already mentioned. That is, they are getting a hallucination like that. Or sometimes they will even spray aerosols directly into their nostrils or mouth. That is again one mark. Okay, so even if you don't know some answers, pray to God, and if you have worked very well, God will see to it that you have matched them properly. That's what I do. I'm sure that you also can do that. Okay, so now see, even after all the preparation, you may not know which is real. For example, you see this one. Is it ulta? Is it real? This was taken when we went to Venice. Venice, has very clean water. And one is the reflection of the other. Which is the reflection? Which is the water? Which is the sky? You will have some difficulty. But then you will have to again keep on looking at it. Keep on looking at it. You see a bench here. This bench cannot hang down. So this means this picture is ulta. So you see, you read the question carefully. You again think over what you have learned, and then you will get the right answer. Okay, so it is time now, 1 hour. Thank you very much. Wishing you all the best for your coming exams. Always remember, nothing great about OSCE. Nothing great. Okay, may God bless you all. And once again, thanking IAP for giving me this opportunity. Actually, after 11 years, I am venturing into this. I was a bit apprehensive, and I hope I have done some justice to your expectation. Thank you.
Thank you, madam. It was an excellent session, madam. It is not some justice. You have did full justice to the topic. Actually, it is not a OSCE class, but it's an OSCE training. How to approach, how to think, what is the common mistakes, all the aspects you covered with 1 dozen of questions. Actually, the OSCE is 25 station, the coming OSCE. It is the same thing will happen on 28th July. You will have questions in the screen. You will not get the time to recollect or go back the question. All the aspects were covered by this session. Actually, my decision was right. It's proved you have to take a class on OSCE. And for the students, the students who missed this session, tell your friends. It will be available in the YouTube, because all the exam going DNB students, it is a very useful, worthwhile session. So ask your friends to see if anybody missed that session. Actually, it was very useful, madam. Even after, actually, I have another engagement, but throughout these 12 questions, I also sat back because I have to prepare a draft for another meeting, but I didn't do that. I also learned a lot. Only the great teachers can do. Great teachers can do like this. Thank you, madam. Really, thank you. Really,
thank you, Ashraf, for the nice words. And thank you, Krishna Mohan, for keeping time. I hope the students who have answered the questions would have, the total marks will come to, I think, 96 or 95. I did not make it into 100 because, making 100 is not good. Leaving something open, that is what. So that is why it is not 100. It is somewhere around 95 or 96. Yeah, I purposefully left it like that. Yeah.
Over to Nihas for vote of thanks.
Thank you, sir. Once again, Lulu madam, it is so nice. I had a feeling of sitting in your class and taking this down and writing again. So that Thank you, madam, for that nice session. Thank you, Krishnamohan, for keeping the time, and all the seniors and members and PG students who joined us. Thank you all for joining us. This session will be completely available in our IAP Calicut YouTube channel. So as Ashraf sir told, whoever has missed it should see before going for the exams. Thank you, madam, again. Thank you, Ashraf sir, and all Krishnamohan, Renjit, Nabil, who hosted this meeting. Thank you all for joining us. Thank you.
I also saw this place, madam. I also went to the Venice.
Yeah?
I also went to the Venice when I visited my daughter at Paris. The same picture.
Yeah.
Thank you, madam. Really,
Thank
it
you.
was excellent. ശരിയല്ലേ
അതെ.
ഏതൊക്കെ മറ്റേ TOT ഉണ്ട്.
Nabil, okay. Nabil.